Yeah, I'm sorry. My computer wouldn't log on. So I'm sorry. Um, yeah, so I'm gonna just get started. Thank you everyone for attending this grand round today. Um, uh, I'm going to introduce our today's speaker, who is Dr. Sangeeta Shah. Um, Dr. Shah is a medical director of adult congenital heart disease and cardio OB. She currently participates in advanced cardiovascular imaging. She moved to Richmond in 2020 from her home state of Louisiana with her husband and 2 children. She is currently on the Intersocietal Accreditation Commission, as well as Cardiovascular Credentialing International Board, and was past governor of Louisiana American College of Cardiology, president of Imaging Society of Louisiana, and in the first class of American Society of Echocardiography Leadership Academy. She has authored numerous articles and given frequent lectures at both professional conferences and her own institutions. Her most recent publication include the prosthetic valve guideline and outcome of transposition of great aortas. Patients after atrial switch. Her various research projects include improving the value of cardiovascular imaging in endocarditis, exercise in adult congenital heart disease, and is developing a community initiative to reduce the disparity in hypertension with a program to teach children. Today, Dr. Shah is going to give us a presentation on the utility of CPET in adult congenital heart disease. It's my pleasure to welcome Dr. Shah to give us a presentation. Thank you.
Thank you, David, for that. Thank you for this invitation to give grand rounds. So I have been heavily involved in imaging. And then what's been beautiful is I always knew in the back of my mind that exercise was going to be important for adult congenital heart disease as the population ages. And I came to an institution which is very strong in cardiopulmonary stress testing. And it's been remarkable to use CPETs in the diagnosis and treatment of this patient population. So I hope to take you through this journey of what I've learned, how to utilize CPET, and what we should be thinking about, not only in adult congenital heart disease, but as you look globally, what we can think about in other patient populations. Just to remind everybody, this is a CME lecture. Please text 31378 to 804-623-4041, and I'll put the code up again at the end of the lecture. So just like I said, we're going to be simplifying the complex is what I hope to do today. In the US, the adult congenital population in 2016, the literature says was about 1.4 million. And there's a growth of this population of about 5% per year. So if we were to look in the United States currently, there's 2 million patients. And the reason that I highlight that, not for my job security, but also to highlight that everyone is going to be involved in these patients' care and will be exposed to these patients. So a little bit of knowledge will really help for the care of these patients. Another thing to put just in a little perspective as we talk about adult congenital heart disease, we always think of Down syndrome. Adult Down syndrome, there's about 130,000 adults with Down syndrome in the United States, and adult congenital in whole is 2 million. So what do we usually do to recognize adult congenital heart disease and to treat its complications? We use echo, MRI, EKG, and labs. And then from an invasive perspective, we use cardiac catheterization. But today I want to show you what stress testing can do. Exercise in congenital heart disease. They often have limited exercise capacity. Why is that? It could be that they have diastolic dysfunction, they have valvular dysfunction, They often have lung disease. Once you have cardiac surgery, you get a little bit of restrictive lung disease. They may develop increased pulmonary vascular resistance. They may have cyanosis. They may have a normal EF visually, but reduced cardiac index. There's a lot of discussion about sarcopenia in this population. And then overall, they're deconditioned. They were told to keep it safe. Don't do anything exertion when they're babies. And sometimes that mindset continues with them. So why do we use stress testing in adult congenital heart disease? Patients tell me, I feel fine. Well, do I really need that heart intervention? Will these medicines really help me? How will weight loss help me? What's causing my symptoms? Can I have a baby? So these are the kind of questions that I get, and it gets very complicated based on the different diagnoses that we have to give these patients a great answer. I think of cardiopulmonary stress testing as a routine check engine kind of thing. You take your car to be serviced so that you don't end up at 7:30 in the morning with one of these lights in your car. And to me, doing cardiopulmonary stress testing prevents this. This would be a hospitalization, in my opinion. So if I check under the hood, if I make sure everything's okay, I can predict symptoms for these patients. I can guide them before they end up in the hospital, because we know once they end up in the hospital, their morbidity and mortality increases. So for me, cardiopulmonary stress test, the way that I'm looking at gas exchange, you breathe in, you're ventilating your lungs. We got oxygenated blood going in. You have a saturation that is supposed to be high, 98 to 100%. The VO2 is what is delivered to the muscle. What comes out of the muscle is VCO2. And then we have this is supposed to be VCO2 here, of your mixed venous coming back in and then getting oxygenated by the lungs. When you look at CPET parameters, work, that we can look at by the RER. Did someone give enough effort for this stress test? We're looking at target heart rate, just like we do in all other stress tests. And then we can look at the workload, which is your metabolic equivalence in these patient population. From a cardiovascular standpoint, we're looking at chronotropic response. Did their heart rate increase like it was supposed to? Did their blood pressure increase like it's supposed to? What happened to their oxygen pulse? And I'm going to highlight oxygen pulse because the CPET team, Justin and I, have been very intrigued by this. Oxygen pulse is a reflection of, does your stroke volume increase when you exercise? And is that a surrogate? Like I said, some of the congenital heart disease patients, they have a normal EF. However, their cardiac index is low. And before I take them for cardiac cath or any invasive test, oxygen pulse could be a good surrogate. And then, of course, paying attention to their EKG for arrhythmias, any EKG changes. From a ventilation perfusion standpoint, we look at VE, VCO2, their saturations, and their peak VO2 or peak VO2 percentage. And always paying attention to symptoms. Even in adult congenital heart disease patients, they can develop claudication over time. And so even claudication symptoms are very important to us. Going step by step through the parameters that CPET allows us to gain. So weight is a very important parameter. RER, so the RER is plot 8 right here. And the reason I'm just showing you the overview is because as I go through the cases, I'm going to show these parameters on these patients. RER greater than 1, which is right here in plot 8. You look at blood pressure and saturations. Plot 9 is your saturations, and it is your green line coming across. We look at peak VO2 as an absolute number and percentage, and that is represented in a couple up here in that's plot 3. And then oxygen pulse, which is what I was talking about. You want it to be greater than 80%. And here is oxygen pulse. So as your heart rate increases, your ability to increase your stroke volume generally should increase as well. So looking at a blunted oxygen pulse may mean that their heart rate's increasing, but their oxygen pulse or their stroke volume is not. Looking at chronotropic response, as well as VE, VCO2, which is how efficiently do you exhale the carbon dioxide that is formed? And you want a number less than 30. From the data for adult congenital heart disease, in 2012, we all thought, this was about 10 years ago, this was a revolutionary article. We now had something to discuss with our patients because we were winging it based on the normal population. And what they did is they took 2,000 of their own patients, found 2,000 other patients from a multitude of other institutions, and with 4,000 patients, they came up with what we call a normogram for us. So, for example, tetralogy of Fallot, which is in this graph, they're telling me that what the curve is. They're saying most of them reach about 72% of predicted. Their average peak VO2 is about 25, and the mean age of this population was about 31. And to give you a perspective, for normal individuals without congenital heart disease, the peak VO2 is generally 30 to 50. Predicted is about 84%, and an athlete's peak VO2 is about 80. They also took this data and then gave us a huge graph, which tells you peak VO2 on one side, and it gives you the diseases up here at the top. And so I can look for a tetralogy of Fallot. The light gray lines was male, the dark gray was females. What is the average peak VO2 for this group of individuals, and what is their range? What is interesting is that they wanted to compare this to other activities. So in Eisenmenger's, if you notice, cooking is here, cleaning is here. They may not be able to do cleaning, but they would be able to do cooking. Don't know how I use this a lot, but it's just an interesting comparison. So knowing that little bit of information, we're going to go through some cases. So the first case is a 25-year-old female with symptoms of lightheadedness. She's had a known PFO, and she's had a VSD repair as a child. She's trying to figure out, what is the cause of my symptoms? On the right, I'll always put a picture of the patient's heart. This one, that's supposed to be a PFO, and here's the VSD closure. So when we look at her CPET, weight is 62 kilograms. RER, as we look at the slope and you look across, the peak is about 1.2. Blood pressure response was normal. But when you look here at the saturations curves did fall, and it fell from 98% to 88% with exercise. The oxygen pulse, here's your heart rate increased. Your oxygen pulse was at 90%. There's a little flattening. However, this is probably because she's quite physically fit. If I was to go into the data and look at just VSD by itself, her peak VO2 was 86%, which is 29. An average VSD, if I were to look at the normogram, was 73%. So she exceeds that, with a normal range for these females between 15 and 24. Once again, she exceeds that. Her VCO2 is 37, which is elevated, and she has a normal chronotropic response. So what did we do? We actually investigated by echo her PFO. And what you see here is the shunt is very large. She has normal biventricular function. She has no VSD leak. After PFO closure, look at the improvement. Her SATs go from 98% to 93%, so the curves improve. Oxygen pulse, there's no change. Her VCO2, which is how you blow out your carbon dioxide, decreased as well from 37 to 31. So CPET helps for symptoms. Doc, do I really need this? Will it help me? Why do I need these medications? So this is a 45-year-old DTGA with an inferior baffle stent that presents with heart failure. So DTGA means your heart's switched. I'm just going to leave it at that. And we baffle blood flow across to the other side. This is your left ventricle that is then fed into your pulmonary arteries. Blood comes back through the pulmonary veins, these 4 dots, comes in through your RV and goes out your aorta. Echo showed severely dilated systemic RV, so this RV was dilated with a fractional area shortening of 32, moderate tricuspid regurgitation, and had a positive bubble study. Pro-BNP was only 150 in this individual. When you look at the CPET, weight is 75, RER kind of dips and comes back up, but it's 1.03, so decent. Saturations do decrease to 89%. Oxygen pulse, you can see heart rate's going up. Oxygen pulse is less at 40%, so it's really low. Stroke volume is not increasing as this individual is exercising, and he's dependent on his heart rate for increase. Peak VO2 is about 12. Now, if I were to look at DTGA's, predicted peak VO2 is generally 66%. He's at 31%. And the normal range for these males is 23 to 33. VE-VCO2 is stable, and just as we said, he had an elevated heart rate response, and this was because he was compensating for his stroke volume. Images by CMR. This is a 4-chamber image, your systemic RV, pulmonary venous baffle coming through. You do see the tricuspid regurgitation. This is a nice view for fellows to show the parallel great vessels. This is your aorta, and this is your pulmonary artery with your left PA bifurcation. This is short axis, RV is right here. This is the LV. And I'm just showing this picture because we are always looking for baffle integrity. And this is your SVC baffle that is not stenotic. And here's the stent in your IVC baffle. Here's the numbers by cardiac MRI, RVEF 48%, not bad. LVEF 64% and tricuspid regurgitation of 18. This is just showing in comparison. So the bubbles are in the left ventricle, and we're looking for any bubbles is systemic. And there's just a few bubbles, so not very many bubbles to explain all the findings. He was optimized on heart failure medications, and his weight is 74 kilos. RER has improved to 1.19. And then what you'll see in the peak VO2 pulse ox, sorry, not pulse ox. His pulse ox has improved in the desaturation. He's going from 99 to 94, but the oxygen pulse has improved dramatically in this individual. His peak VO2 is 18, improved from 11, however, still not to baseline for a DTGA, but much better, and his VE-VCO2 has dropped. His chronotropic response has improved dramatically. So, another reason, looking under the hood, is what cardiac intervention should I have and how should I piece it together? This is a 42-year-old male with dextrocardia. That's why the heart's pointing to the right in this picture. He was born with tetralogy of Fallot. He has a right-sided aortic arch. He was having significant dyspnea and bentopnea. Every time he bent down to put on his shoes, he's like, I get short of breath. His pro-BNP is 475. And so what we know, I'm going to show you, his baseline CPET showed a weight of 75 kilos. RER was pretty good. So I'm showing you patients with good RERs. They're pretty good effort for us. Here's your slope. His blood pressure had good blood pressure response. Oxygenation went from 92 to 87%. And you see this dip over here. His oxygen pulse is 67%, and you can see the purple line kind of come up and then just flatten completely. His heart rate response is also, he does not increase his heart rate to augment his stroke volume. His peak VO2 was at 36% predicted. He should be around 72% predicted, and his VE-VCO2 is slightly elevated. This is his heart. His right ventricle is right here. His left ventricle is right here. I've stopped saying right and left as I give lectures. Here's his pulmonic valve. And what you notice is that there is the same amount of backward flow is going forward. So this is severe pulmonary regurgitation. What we did in this individual is give him a new pulmonary valve. From that new pulmonary valve and optimization of medications, we were able to show with weight loss, he went from 75 to 69. RER is good. He increases it to 1. Oxygenation, he no longer goes down to 87%. He's now at 92. Oxygen pulse has improved. His heart rate response has improved, as you see here. And his VE VCO2 is pretty good. So pretty good in success. So we still question, why is he hypoxic? Didn't have a great explanation for that. And so I'll show you what happens. I just want to put a plug in for arrhythmia while you're looking for CPETs. He actually did have ventricular tachycardia short runs of and resulted in an ICD. This is a CAT scan. Right atrium is right here, right ventricle. Here's your coronary sinus. I want you to follow the coronary sinus, and you can see the coronary sinus connects to the left atrium. You can actually see a blush of contrast here in the left atrium. That is an unroofed coronary sinus, which is a very rare type of ASD that is causing his hypoxemia. So this is another case. I have a 33-year-old female who has a unicuspid valve. She exercises regularly. She's on the treadmill. She does janitorial work at the gym. And she's like, I feel fine. Why do I need anything done? Her baseline CPET. Her weight is 56 kilos. Her RER, you can see her slope really good at 1.1. She has a blunted blood pressure response. Her oxygen saturations are maintained, as you see here in the green line. Her oxygen pulse augments appropriately at 88%. Her peak VO2 is at 83%, not bad compared to the normogram I showed you. She has a normal slope for her ventilatory CO2, and she has normal chronotropic response. So she's not doing bad. But what does she have? With this unicuspid valve, as you see here, this is a cardiac MRI. There's fusion of your two cusps right here and right here. So this makes it a unicuspid. Her ascending aorta measures 36 millimeters. And if you look here, her Doppler through this unicuspid valve, she has 5 meters per second going through it with a mean of 62. So trying to convince her she needed surgery, she's like, but I feel fine. Why do I need it? So I told her, well, we'll just repeat your CPET over time and closely follow you and then go from there. So that's what we did. So this is a repeat CPET. Her weight is completely stable. Her RER, she still puts a good effort in. This time her blood pressure response decreased. And so everything else was still the same. She still increased her oxygen pulse. Her heart rate still increased. Her VE VCO2 slightly increased. And we convinced her that probably now is the time for surgery. And she did actually have surgery on Tuesday of this week. So putting the last case, and I'm sorry this ended up on top of the wording, but basically this is a 24-year-old pulmonary atresia with intact septum. And just to highlight a picture of his heart on the right of your screen, he basically works as a single ventricle physiology. Here's his pulmonary atresia. Here's his right ventricle. It's not contributing. We're rerouting blood flow from the IVC into his pulmonary circulation, SVC into the pulmonary circulation. And then this is just showing, I couldn't draw the SVC up here, but basically SVC looked fine, but because of the pressures has lots of collaterals from the systemic venous blue blood to the pulmonary veins, which is pink blood. And as we take care of him, he's like, well, show me how weight loss will help me. I feel fine. And which medicines will truly help, because I don't want to pay for all of these, which is reasonable. So his CPET baseline weight of 94 kilograms here. RER is 1.0. You can see the slope is really good. His oxygen saturations baseline is 88%. He dips down to 81%, and you can see the green line going down. Oxygen pulse, it's decreased, but it's at 75%. Remember, we want this at above 80%. His peak VO2 is at 54% predicted. A Fontan should be about 59, and his VE VCO2 slope is increased. So we started at Circa with our consultation with our pulmonary hypertension group and started him on routine heart failure medicines after we did a cardiac catheterization. So over the course of time and titration of medicines and having him understand the importance of weight loss, what we see here is that his weight he reduced from 95 to 79 kilograms. RER, as we exercised him, is good at 1.02. Blood pressure response was normal. Saturations, we actually dipped in our saturations, which is interesting, and I'll come up with a plausible explanation for this, is that he only got to 81% last time, and now he's dipping into 74, even with all the weight loss. Oxygen pulse improved, peak VO2, 56%, about the same, and VE VCO2 improved. So what I think happened in this individual is with all of our medicines, I created a shift in his shunting. And I think as much as I still want pulmonary hypertension, and some people say pulmonary hypertension medication should be used in this population, I wonder if that has reduced his oxygen saturations as he has improved his oxygen pulse. So the discussion with our pulmonary hypertension team will be, is what benefit have they seen? Is there anything, repeat right heart cath, and then take them off the Circa is our plan currently. The last case, before I go into some didactics, is case 6. And the question comes up is, can I have a baby? And we use this to help CPET to help decide how will a female tolerate a pregnancy, especially in the Fontan population. So she has dextrocardia, double outlet right ventricle, which meant that both her aorta and her pulmonary artery came off of her right ventricle, which is right here. And she has a right-sided aortic arch. We've rerouted her blood flow. She does have something interesting where her hepatics were directly plugged into her pulmonary arteries, and she doesn't have an IVC. So this is an azygous drainage into the SVC. She does have heterotaxy, which means her abdominal organs are also not in the right place. This is a picture just to give you a visualization of her heart. Right ventricle is on this side, left ventricle is here. We have a large VSD. They have sutured her mitral valve closed. She does have an ASD here, which is not in this individual picture. So blood flow comes in through here and go in. Two other interesting findings is here's her Fontan, the circle here, and there's a Fontan fenestration. So right here. And then here's her aorta, and here's another dilated vessel. If you see another vessel that looks the same size of your aorta, this is what we call a dilated azygous, and it usually means that the IVC does not connect the routine way we normally think, and we call it an interrupted IVC. So what does her peak VO2 look like? Her CPET, her weight is 56 kilograms, very reasonable. Her RER is 1.09, as you see here. Blood pressure response is normal. Saturations, she only desats to 93%. Most Fontans desaturate a little bit because the coronary sinus blood flow goes into your systemic circulation. Oxygen pulse is remarkably wonderful. Heart rate is here. Oxygen pulse increase is here. Her peak VO2 is 57 of predicted. Remember, the average Fontan is 59% of predicted, doing well. An average peak VO2 is 16 to 23 in a Fontan woman, and she's at 21. Her VE VCO2 slope is slightly increased at 31. She has a normal chronotropic response with a max heart rate of 130, and the only reason I'm pointing that out is because I'm going to show you some data in pregnant women. So she successfully delivered this weekend at an outside hospital. It was an amazing team effort of both all our maternal fetal medicine anesthesiologists, corresponding with the team at New River Valley Hospital and delivering the baby vaginally at that hospital. So going into a little bit of literature and discussing this, exercise in Fontans, as I've discussed, they have a lower peak VO2. The normal range is about 50 to 59%. We know that central venous pressure predicts pulmonary blood flow. So what I tell everybody is think of this as an RV infarct. You got to have your tank full in order for the blood flow to spill into your pulmonary arteries and get oxygenated. But you don't want that your tank to be too full because it's passive blood flow that goes in from the Fontan into the pulmonary circulation. Often these patients are dependent on heart rate to increase their stroke volume, their cardiac output, because their stroke volume is fixed. There's only so much forward blood flow we can get through this circuit out the aorta, no matter what the ventricular ejection fraction is. Their exercise is often limited because they have restrictive lung disease. And unfortunately, some of these patients have also added obstructive lung disease by smoking, vaping, and things like that. These patients also have a reduced muscle mass. They haven't been to the gym a lot. They haven't been exercising. They haven't been participating in sports. As they get older, their diastolic pressures of this ventricle increase and their PVR increases with age. And you can see if those two components start going up, how you have decreased volume going into your pulmonary artery, which is decrease in your cardiac index. There's a very good 2 articles that I'm going to show you that came out recently in JACC. This is looking at CPET, proBNP, and exercise hemodynamics in Fontans. Now, I know this is only 50 patients. It's very low compared to our adult cardiovascular research. However, this is amazing that they have 50. The median age is 31. They did CPET's baseline on all these patients. And then in the cath lab, they biked them as they did hemodynamic pressures. And they biked them to an effort where their effort score was greater than 16 and their dyspnea score was greater than 6. So there's a lot of age factors. I just want to highlight a couple of things. Of course, I've circled the proBNP to show you that it's elevated in this population of 322. Average age I've already talked about is 31 in this patient population. What I'll also highlight is a lot of these patients are developing comorbidities, hypertension, diabetes. They often have pacemakers. They're developing cirrhosis, which results in decreased SVR. They're developing renal insufficiency, and they develop valvular regurgitation. And when I help take care of these patients, I always say moderate valvular regurgitation in a Fontan is very, very, very significant because it's a single ventricle handling that volume. Diuretics, we are trying to do what the heart failure team does with these patients, put them on this array of medications to see if we can make them feel better. Average ejection fraction, and I hope I've highlighted this a few times, ejection fraction doesn't mean a lot to me. It does mean something if it's low, but if it's normal, I'm still going to investigate. The amount of valvular regurgitation there is 10% with atrioventricular, so AV valve regurgitation, either mitral or tricuspid. The average peak VO2 in this population was 18 with a percentage of 45. So a sick population is what I'm going to say. Hemoglobin in this population was 14, which means that they weren't very hypoxic at baseline because look, their oxygen saturation is 93%. Let's look at the Fontan pressure, which is the SVC pressure, was about 15 baseline. With their feet up, it was 16. And then when they exercised these patients, some of them went up to 26 millimeters of mercury, which is really a lot. If we look at wedge pressures, baseline is 10, feet up is 13, and with exercise, you get to 22. What this tells us is that these patients their whole heart does not have the capacity with exercise, the interplay between that. So what they were able to show that if a patient had a peak VO2 of less than 50, it was associated with a higher exercise Fontan pressure and wedge pressure. If they had a proBNP greater than 300, this too was associated with a higher exercise and Fontan pressure. Together, if they put the peak VO2 with the proBNP, these individuals had more abnormal hemodynamics. And then they followed these patients to see what MACEs were. And they came up with this diagram, which I thought was really good. And they realized that if your proBNP is increased, your peak VO2 percentage is less than 50, your risk of death, transplantation, arrhythmias, and heart failure hospitalization increases. So once again, a way for us to use in a non-invasive method CPET with a proBNP to estimate who is at risk in this population. Another study, same group, because if you do this well, you write about it a lot, is functional capacity, and they're again looking at the same hemodynamics. What they were able to tease out this time is that the peak heart rate was also a predictor of the hemodynamics. And the reason I want to highlight that is because, as we saw in the case examples, is that they only have heart rate response in the ability to increase their cardiac output, because often they have a fixed stroke volume. So if they cannot get their heart rate up, they won't do as well. So taking that into consideration, what is the CPET in pregnancy outcomes in congenital heart disease? And I'm sorry, I'm not showing you a graph. The graph was very confusing to describe, but basically they looked, and what they were able to predict is that if the mother's heart rate was able to get to greater than 150 and her peak VO2 was greater than 25, then she had a low risk of both maternal and neonatal complications. In the cardio-obstructive population in this, especially in Fontans, we break it down for the mother on what her risks are and what her baby's risks are, because often these babies have very low birth weights and often end up needing to be delivered early. So we always talk about, can we get them to 35, 36 weeks safely so that there's less neonatal complications. So I'd like to go through what Justin's group, I, and a whole bunch of team members have been working on. And I'm going to discuss two abstracts. They're very similar, but wanted to say that this was the first, we started to create a database of all our patients who have had CPETs. So the inclusion criteria is CPETs. From the CPETs, we look and we collect the data from the cardiac MRI and the echoes, and we put that data in. We are not looking at hospitalization or anything like that at this time. But this was one of our first abstracts that we put out to the ACC, and this was only 48 subjects. But if you think about it, that's a huge number given that I just showed you data of 50. So when we first started, we had 48 patients, and we wanted to see what is the MRI predictors, because we have this amazing ability to do echo, CPET, and MRIs on the same day here. And often our patients get something within 6 months to a year of their CPET. And what we were able to show is the oxygen pulse may be a surrogate to left ventricular stroke volume when we look at left ventricular stroke volume by cardiac MRI. And so if you look here, and I know this is small, is the left ventricular stroke volume and the right ventricular stroke volume had a good correlation in this patient population. Going forward to more recently, this came out this year that this was published, and now we have this data was for 262 adult congenital patients who underwent CPET and cardiac MRI within 1 year. And what we were able to show is the same stuff that I've been talking about, is that the oxygen pulse in certain individuals is reduced. And then when we're able to correlate it, we're able to continue to correlate it with ejection fraction as well as stroke volumes, as you see here. So if oxygen, it's interesting that that oxygen pulse in this population is corresponding to more of the stroke volume, which I would like to see. What we've talked about is seeing if we can correlate the oxygen pulse that we see by CPET by measuring stroke volume non-invasively in a cardiac MRI machine. So I think that's where we're hoping to go forward over the long term. I want to thank my team, my family, as well as the CPET team. Thank you, Dr. Ina. Thank you, Justin's team, for allowing me to do some bizarre things in the CPET lab. Thank you for being patient with hypoxemia, dextrocardia, and truly learning with us. I will show the CME code. I have ended quite early. I think whenever I present on congenital heart disease, I feel like people's brains get kind of full early in the morning. And so wanted to leave some time for questions and discussions. And here's the CME code, text 31378.
Hey, thank you, Dr. Shah, for such a nice, complex presentation. But I wanted to ask you for that patient who had heterotraxy in the recent delivery. If she was to seek advice about future pregnancies from you, what counseling or what sort of information would you provide to her?
Yeah. So you were part of those discussions. So that's
Yeah.
you were a part of those discussions. I think there was a couple of lessons learned. There's one definite lesson learned. And I think, so I'm going to tell you the lesson learned for us. I think as a team, we had planned on her delivery on Wednesday in a very methodical way, CT surgery, everybody involved in case there was a complication. What we noticed is that she delivered in another whole hospital who didn't have any resources. And when it was time to life flight, there was no gas. And she actually progressed through delivery so fast, even for a first-time pregnant woman. She went from 3 centimeters to delivery really, really fast. So we didn't have time. So one of the things that we've talked about is now having these patients here in Richmond, if they're somewhere else, earlier at 32 weeks. And if there's any sign of dilatation of the cervix, then having them here immediately, like having them stay at doorways. I think from a pregnancy standpoint, I would ask her to wait for at least 2 years before entertaining another pregnancy. I think I would go through probably just as systematically as we did before, the same stress testing, labs, echo, and potential cardiac cath. These patients, if you're going to get pregnant, you get a cardiac cath every 5 years because I need to see what your cardiac index and your Fontan pressures are before I send you to surgery. So I would support her as long as I've tested her before that. And one thing I want to highlight is that C-section is not the safest maneuver in these patients and should be avoided at all times. So C-sections and spinal anesthesia should be avoided. The spinal creates hypotension and the C-section creates hypotension and decrease in preload suddenly, and that's what you want to avoid. Again, they're an RV infarct, don't decrease preload at all costs in these individuals.
Thank you so much.
All right. Justin, are you on? I was going to have Justin comment, but all right. Well, thank you, everyone. And I'll give you some of your morning back. Take care.
Take care. Thank you.